A very good morning, everybody. I'm Dr. Sheetal Bakshi, oculoplastic consultant, Medanta, New Delhi. Today I'm going to talk about a rare case of hydatid cyst of orbit. A 29-year-old male came to us with the chief complaints of swelling under right eye lower lid since 2 years. There was no other associated complaints. The swelling was very small initially and gradually increased to the present size. There was no other systemic history or past surgeries, medication, or known allergies. Vision was 6/6 and 6. Anterior and posterior segment examination was perfectly normal except for the mass. On inspection, a round mass under lower lid was seen with mild superior dystocia. On palpation, 2 by 1.5 centimeter round, firm, incompressible, non-tender cystic mass was found under lower fornix. Mass was not attached to overlying skin or underlying structures. Color and temperature were normal. Hertel's exophthalmometry was 20 mm in both the eyes. Retropulsion and Valsalva negative, transillumination positive, no palpable pulsation or bruit. On contrast enhanced CT scan, we can see there is a thin-walled, oval, well-defined, homogeneous cystic lesion in inferior fornix. We can see by the arrow, the mass is as big as the eyeball itself, and it is pressing on the eyeball and indenting it. Patient was managed surgically under local anesthesia with sedation. Inferior orbitotomy was done by taking a conjunctival incision. Tissue was dissected, retracted, cyst exposed. The cyst burst in between the surgery. The residual fluid was collected and sent for cytology. The cyst itself was sent for histopathology. Tissues were washed thoroughly with hypertonic saline. Conjunctiva was sutured with 6-0 Vicryl. Post-op day 1, patient was doing good. Post-op day 7, he had some bogginess under eyelid, which subsequently subsided. The mass was around 2 cm in diameter. It gave a very typical proligary membrane appearance of a hydatid cyst. Histopathology confirmed the diagnosis. We can see the lamellated membranes and typical hooklets. After diagnosis, patient was referred to an infectious disease specialist. He ordered extra investigations like ultrasound, abdomen, chest X-ray, blood counts, liver function tests, and serology for echinococcus. Everything was reported normal, but still we gave patient tablet albendazole for 3 months as a precaution. There are many differentials of a cystic lesion of orbit. The closest to our case are dermoid cyst, epidermoid cyst, conjunctival cysts, and apocrine hydrocystoma. Some important points of discussion regarding this case. Hydatid cyst is a parasitic tapeworm infection caused by larval form of echinococcus granulosus. Dogs are the primary hosts, sheep are the secondary host, and humans are accidental hosts. The disease is very common in cattle rearing areas like Latin America, Mediterranean countries, Middle East, New Zealand, Australia, and of course India. Main organs affected are liver, lung, and spleen. Orbital affection is only less than 1%. So that makes our case a little bit rare. This is the full life cycle of hydatid cyst. I would like to conclude by saying that orbital cysts are very common. We should keep them in mind while dealing with orbital cyst. Histopathology is must for any case. Systemic complications should be kept in mind. Travel history is very important for endemic diseases. Follow-up is equally important because these tend to, there could be seeds in other organs. Education and veterinary services availability is also important. Thank you. It's been great time in Amritsar. Thank you,